Hi, good afternoon. My name is Lydia Pecker. We're so glad that you can join us for our session, Doing It Well, Sex, Family Planning, and Sickle Cell Disease. I'm here in Baltimore, and I'm joined by Tiana Wolford, Philip Okwo, and Brittany Snape, who are amazing patient advocates who are going to teach us a lot today, I hope. My job is to give you a little bit of background about this topic. And so in a few brief slides, I'm going to frame some of these issues. And of course, we acknowledge up front that this overview necessarily shortchanges every last one of these issues, which could themselves each be a talk. So we know that sickle cell disease touches every aspect of life, and increasingly we recognize that sickle cell disease touches relationships and sexual health and reproductive health. And we really, folks on this panel and me, we really think the time has come to talk a little more about that. So we're really glad for this opportunity. We know that children and young people with sickle cell disease experience delayed puberty, and we think a lot about how that affects the social experiences of life, not just dating, but also how you meet and become friends with peers and what you talk about and how you talk about it. For women with sickle cell disease, we know that menstruation is a challenge. Many women experience pain with their menses, and about a third of women experience sickle cell pain with their menses. It's possible that some of these symptoms are relieved by hormonal therapy, more often called contraception, but there aren't great studies about that yet. Hormones, which here I consider to refer broadly to both hormones such as contraceptive hormones used to treat menstrual pain and also to prevent pregnancy, but also for individuals who are transgender. We don't know a lot about the safety and effectiveness of the use of those hormones. We recommend strongly progesterone-only contraception for women with sickle cell disease because of the risk of blood clot associated with estrogens. And of course, this creates a conundrum for transgender women who may be pursuing estrogen therapy as part of their cross-sex hormone therapy. We are increasingly recognizing sickle cell disease and its treatments and cures as a risk to fertility, and as a broader opportunities for fertility preservation are available because of advances in science, which make fertility preservation for girls and women standards of care. We're confronted with how to expand this opportunity and address this opportunity with our patients and with which patients. Preconception care is a big can of worms, and we worry about women's end organs. We worry about which medications they're taking before they become pregnant and while they are pregnant. And we know that women with sickle cell disease need to expand their care team as they pursue pregnancy and are pregnant. And so that also can be disruptive in terms of health and well-being. Pregnancy itself is high risk, and there are few treatment options during pregnancy. Transfusions are really the one treatment option, and there's not agreement about when they should be used. And again, that care team becomes more complex. For men with sickle cell disease who are surely shortchanged on this slide, we know that priapism and erectile dysfunction are real both psychological challenges and physical challenges, and we lack great interventions to address them. We also know more about how sickle cell disease affects sexual and romantic relationships, and certainly we can learn a lot about that from our panelists today. But in the list that I was thinking through about how sickle cell disease touches these experiences, so sex itself, so women with sickle cell disease may be at risk for having dyspareunia, which means pain when you have sex, priapism or prolonged detumescence, which means it takes a long time for your penis to get unerect, erectile dysfunction, and pain with excitement is something that pediatric patients with sickle cell disease are recognized as having in all other settings. So some parents describe that children with sickle cell disease, when they get excited, they get pain crises. But in adults, and especially very brave young adults who are talking more about their experiences, we learn also that sexual excitement may be associated with pain. Sexually transmitted infections are a risk for infertility and need to be addressed in our population. Often this is a task for primary care doctors, but not all of our patients have primary care doctors. Partner testing is critical and should be performed with a hemoglobin electrophoresis. We know that the wrong test is ordered. We know that tests are not ordered. We know that tests may be misinterpreted. And so this is a real challenge for some of our patients. I recently sent a patient for genetic counseling who finally agreed to go and shared with me that she needed this more than she realized. And so I would suggest to you, even if you think you know a lot about sickle cell disease and how it is inherited and how it is passed on, that genetic counseling it can be a powerful experience. And also that genetics counselors are really trained to talk about genetic information in a way that physicians are not. And so they may have a set of skills for communicating ideas that can be useful to individuals with sickle cell disease and their families. Fertility assessments are not yet standardized. We usually perform them before bone marrow transplant and gene therapy. But other than that, we have not started using fertility assessments in any systematic way in our patients or families. And then in family building, we rely on our patients to lead on what they imagine and what they hope for, and then to engage with them about what the possibilities are. Pregnancy planning, we talked a little bit about that on the previous slide, but if you plan first, you can inform your treatment and care. And then we don't know.
Lydia, just real quick, your slides for some reason aren't advancing from our view.
I don't, really?
Yeah.
Well, they look great to me. I can keep talking. There's only one more and you haven't missed any pictures.
Okay, it's fine. We see the first one, but for some reason it's not.
Oh, I'm so sorry. They're all really nice black and white slides. And okay, so I'm just going to go to the last slide since that's where we were headed anyway. And I'm sorry. Oh, it says screen sharing is paused. What if I stop sharing and start again? Oh dear. Okay, I'm going to try one more time, just so you get this last slide has a lot of ideas. Can you see this, a new slide?
Yeah, we see them now.
Okay, so see how this is a big list? That's what we just went through. So everybody can think a little bit about that: sex, STIs, partner testing, genetic counseling, family building. And then the last thing I wanted to talk about, and this is a perspective that we can bring as pediatric and adult hematologists, but also as patients, that we need to be anticipating that sexual and reproductive health care are going to be issues and challenges for our patients, that our patients are going to need big teams to take care of them in this setting, and that they will have a lot of questions. And I think we should expect lots of questions because it's really, it's not a monolithic entity. There's a lot of choices here. And we know that pediatric and adult sickle cell providers have roles to play. This is a brainstorm of the kinds of people you want on your care team as you think about your reproductive health options and you think about your sexual health. Family, trusted friends, romantic partners, primary care doctors, hematologists, obstetrics and gynecologists, particularly high-risk obstetrics, which is also called maternal fetal medicine. You may need to consult with a reproductive endocrinologist or infertility specialist, a urologist, a genetics counselor, and I didn't want to shortchange mental health care here. I think it's time that we acknowledge that dreams about reproduction and family building are very human dreams, and that when those dreams get disrupted, it can be very disturbing, depressing, and upsetting for people as they go through that. And so I certainly think of mental health care experts as part of this picture. There is an NHLBI guideline that says that all individuals with sickle cell disease should develop a reproductive life plan. We don't know how to implement this guideline, but it's certainly something where patients can help lead the way. And so I would suggest to you as patients who are out there, you may want to learn more about the effects of sickle cell disease itself on reproduction, on sperm and on eggs, and on ovaries and on testicles, the effects of therapies on those things. You may wish to learn more about how we measure fertility and preserve fertility. You may wish to start anticipating planning your pregnancy, and you may also wish to think about preventing pregnancy. In vitro fertilization with pre-implantation genetic testing may be important to some families who are at risk for having a child with sickle cell disease and would like to learn about that reproductive option. And then, of course, breastfeeding and parenting, which again, each their own talks, are not often addressed. And those were my slides because we have this amazing group of panelists who are here with us today, and I think it's better to hear from them about questions as we go forward. I see that all of my notes say my slides were not moving. Sorry about that. So I think it would be great to hear from each of you first a little bit about what brings you to this panel today. I'll give you each about 2 minutes. Ms. Wolford, you want to start?
Me too. So I am 29 years old. I was born with sickle cell SS, and I am the co-founder and CEO of SC Red, which stands for the Sickle Cell Reproductive Health Education Directive. It is the first and only organization to focus solely on reproductive health, and we are brand new, and it's a huge undertaking, but we're really excited about the potential, and I'm happy to lend my voice to this panel.
Ms. Snape.
Hello, I am Brittany Snape. I am almost 31 tomorrow. I have sickle cell SS, and my background is as a registered nurse focusing on neonatal intensive care. And as of late, I've been getting very interested in reproductive health. So looking into that and how I can help others with chronic diseases approach that journey. So thanks for having me.
And Mr. Okwo.
Thanks, Dr. Pecker. Good afternoon, everyone. Thanks for joining this symposium. My name is Phil Okwo, and I am a warrior with sickle beta 0 thalassemia. I am 39, turning 40 in about 20 days. So a big milestone, of course, for those of us sickle cell warriors. But I am a father of 2 young trait warriors, my 5-year-old son, Theophilus, and my 2-year-old daughter, Chimamanda. And, you know, my big passion is of course community health and patient advocacy on behalf of this community. So I'm excited to share my experience in this conversation, and hopefully it will help to answer some questions and I guess make discussion easier for some warriors in the audience and their providers.
Great. Thank you so much. So, you know, this is my chance to ask questions that I don't always get to ask. So I'm going to start with one for Ms. Snape. Since tomorrow's your birthday, let's start with a happy topic. Tell us about meeting your husband and a little bit about what it was like to share with him that you had sickle cell disease.
Okay. So I actually had to ask my husband this last night because it's been so long, but we actually met in high school, and we were just friends in high school, and then, you know, started dating more seriously. And at that time we were in 2 different states. And I remember he came home, I think for like a Christmas break or something. And I was admitted in the hospital, and he just was like texting me, trying to see me. And I'm like, no, this is not a good time. You know, I'm not feeling well, things like that. And then I believe he just kept pushing and wouldn't leave the issue because he wanted to see me. So I ended up, you know, telling him that I had sickle cell disease. I was in crises. I was in the hospital. And I think at that time, he wasn't, you know, very aware of what sickle cell disease was. And just like through our relationship and marriage, it has been a crash course in sickle cell disease for him. So he's really learning a lot. And I think the most important thing is when you're telling your partner, significant other, that you do have sickle cell disease, is to be open and honest, and unfortunately kind of talk about what this means and how this could impact our relationship. And if that's the person for you, then that'll be the person for you. So that's how I told him many years ago.
Wow. All right, so everybody gets an intro topic question. Mr. Okwo, will you talk a little bit about trait testing in your children and what that experience has been like for you, and about having children with your partner?
Yes, absolutely. So thank you for that question. So as far as having the trait testing done for my kids, it's part of the kind of standard slate of tests, newborn screening that's administered here in the state of Georgia, where both of them were born. There wasn't necessarily much fanfare. There wasn't even necessarily, I don't believe, a very extensive kind of communication about what the implications of, you know, reproductively for for my young kids. And I think that creates actually probably one of the biggest opportunities as it pertains to trait testing. I mean, it's great that we have it pretty much universally here in the United States, but I think there's the handoff and the awareness that needs to follow what it means to have the trait, although there may not be clinical implications directly, except for extreme circumstances. That, for one, is not a guarantee. And there are many people with trait who are arriving at parenthood completely unaware about sickle cell and the potential that they can pass it on to their children. And so a big part of the advocacy work that I do and joining conversations like this is so that my children won't have to deal with that, right? And so I think that's definitely something that hopefully will be a good takeaway from this discussion.
And what's it been like being a parent as you live with sickle cell disease?
Oh, it's funny. I don't know if I'm overprotective of the kids in the sense of I pretty much treat them. I try to, do all the sickle cell concerns, hydrate them the same way I do. I try to make sure that they're not getting too dehydrated or spending too much time in the sun. But the biggest thing for me that is kind of looming large is just the potential that, again, a generation from now, either one of them could have children who might have sickle cell. And so I have an equal amount of concern for the grandchildren that I may or may not get to meet, but, knock on wood, I'm doing everything in my power to make sure I get to kiss those grandbabies, and just making sure that should that be what my kids have to deal with, that they are fully prepared. And it's a lot. It's having to take that generational view is so important, because I was able to reach that milestone of being able to have kids and fortunate enough to do that. But it doesn't necessarily, you can't necessarily breathe that sigh of relief that, okay, well, my children have the trait, and so the job is done, right?
Thank you. That's really a great answer. A lot to think about too. Ms. Wolford, it's your turn. Some folks maybe have heard you talk a little bit about your experience with fertility and counseling or lack thereof. Would you talk a little bit about your experience with fertility and how that brings you to the work you're doing about fertility preservation in the sickle cell community?
Sure, happy to get into the heavy stuff. So about 10 years ago, I had a haplo bone marrow transplant, and it was at a time in my life where I was feeling pretty desperate. Like, I just wasn't living the quality of life that I wanted to live. So I was approached about initially joining the Be the Match registry, and like so many of us, I did not have a match. So then I got approached about doing a haplo transplant. And my only real hesitation, because I was just so ready to be cured, and that was all I was really thinking about. But I did have one hesitation, and it was being infertile. And I remember sharing that during my informed consent process and kind of being dismissed and told that I shouldn't even be worried about the transplant making me infertile, because with all my complications from sickle cell, I was probably already infertile. And so that was hard to hear at age 19, but now, like, at age almost 30, it's been a lot more devastating. And so I really just want to make sure that we make fertility preservation more accessible to the sickle cell community, especially for sickle cell warriors who are undergoing these curative therapies. And, I know we do a lot of comparisons to cancer, but from my own research, because I recently got into researching resources, because the cost for egg freezing is astronomical, and like insurance doesn't cover that. And what I found was that there are so many resources for cancer patients. There are laws and policies in place, and there's also a lot of philanthropic work. There's a lot of grants that they have access to that we don't. And that's kind of my initial inspiration for starting the organization, I just wanted to give away grants so that people could preserve their fertility. And then it just grew into something much bigger. But I think that it's something that we as a community have to work on together. It's going to take a collective effort to make sure that people in this community don't have to potentially give up their dream to have a family in the future.
Thanks, Tiana. We can't hear your story enough. One thing that your story always makes me think about as a doctor is I always think about the things that I should have done differently when I was taking care of pediatric patients, and the things that I do differently now that I take care of young adults. And I wondered if you all would comment a little bit on things that you wish that your doctor had talked to you about, or that you had the courage to talk to your doctor about when you were maybe somewhere between 12 and 16 years old. So either what would you say to your 12 or 16-year-old self, or what would you like the doctors to have said to you about sexual and reproductive health?
Well, I'll start, because when I reflect back into like pediatric care, I honestly don't remember having a lot of conversations about reproductive health. So I think it starts there, and just making sure that these conversations come up, because there's so much to go over. We know that sickle cell can impact you in so many ways. So we're covering pain and fatigue, but I don't really feel like reproductive health got a nod. So I think that I just wish it would have been brought up more.
Great. Either one of the other panelists want to talk about this issue?
Go ahead, Brittany.
Yes, I would agree with Tiana. I feel like I can't recall ever discussing this in peds, and I think there's also a way to say like tell a 12-year-old like, well, it's appropriate, age appropriate sex education or reproductive health. I probably wasn't ready for the conversation of, do you want to have children and how many kids do you want? But having that conversation to maybe start thinking about it, or when I started taking hydroxyurea, having that conversation regarding like, well, this could impact your fertility or your ovarian reserve down the line, and how do we want to approach that before starting this therapy? I think those would have been good conversations to have.
I will definitely second a few of those comments. In particular, I would even say leading up to, this kind of age appropriate conversation that Brittany just alluded to is perhaps bracing us, those of us who are approaching that transition age, for the fact that developmentally we may be behind. And so I know my dad, having been a doctor, knew to kind of take me to an endocrinologist when it was very clear that my development was it had slowed quite a bit. And so, I think by the time I graduated high school, I still hadn't really begun puberty, and I was maybe 5'4" at the time I graduated. And so there was a lot of discussion around that, and looking into where my bone age was relative to my actual age. And I think that probably could have been an appropriate segue for some of the reproductive discussions and planning about that. And then I would definitely say that there are opportunities to have discussion about potentially how your sexual experience might differ from what you may have heard, given your sickle cell condition, and what kinds of things to potentially prepare yourself for mentally in advance of that,
and
amongst others. So.
And one question that is in the chat, and there are over 80 people at this conference. Surely you have one question for our amazing panelists who are willing to bravely speak to you about all these topics. But one question that's come up in the chat, Phil, is about sex leading to pain. And the question is partially about whether there's research that has been done on this subject, and you guys can answer that question because you know the answer. But as there has not been much research done on this question, I thought you could also speak about what you've learned because of your activities, by your personal experience, but also by your community engagement activities. You want to start with that, Phil?
Sure, we'll start with that. It's a great question. Thank you for whoever posed it, and let's definitely get some more questions in here. Yes, it is possible that sexual intercourse can lead to a crisis. I'm fortunate that though that I don't, I've not experienced that. For me, as a young man with sickle cell, I think for those of us males particularly have to be concerned about such things as priapism, right? And so I know even for me, although I haven't had a really extensive priapism experience, you know, for example, my first sexual encounter was not, it wasn't very comfortable, to say the least. I guess not to dress it up in any much, but it certainly was not the way that kind of most sexual encounter for the first time for most men is depicted in the media or anything like that. And so if you're a young warrior, that might be something you want to make sure you brace yourself by potentially having a discussion with your doctor about some of the things you should anticipate with regards to that. And so in my first early sexual encounters, there was definitely some discomfort there, and it wasn't it just wasn't necessarily very always as pleasing as sex can be. And so kind of learning how to orient your body and some of the things to kind of think about is definitely an opportunity, I think, in discussions for young warriors. So
Great. And I want to just a little bit specifically answer or talk about this question about the data. So, you know, we have one paper about dyspareunia pain with sex in women with sickle cell disease. And I think it's reasonable to think this is an under-acknowledged problem, right? We know sickle cell disease is associated with a chronic pain syndrome. And we know that chronic pain, individuals with chronic pain syndromes are at increased risk for having pain when they have sex. So I think it's reasonable to wonder if this is an underappreciated experience for individuals with sickle cell disease. And then of course, the second thing I wonder is how the medications you can use to prevent crises in other settings might also affect sexual health. And certainly that study has not yet been performed, but is a question that I always have about hydroxyurea and our other treatments. Here is oh, go ahead.
I'm sorry, I just wanted to kind of speak to that from a community perspective, because like Phil, I can't really relate to that personally, but the sickle cell community, I think that as we age, there becomes a greater disconnect between healthcare providers and patients. So a lot of times what I see as an advocate in this space is that the warriors will go to each other before they will go to their doctors. So I see the pain with sex complication all over social media, and people are saying that they're really embarrassed, like they don't know how to talk to their doctor or to their partner about it. And that's one of the things that my organization will try to help. We want to like educate and empower warriors to feel more comfortable having these conversations, but I definitely see that come up, and I just think that there's like a lot of shame and embarrassment, so we need to break that stigma.
So well said. Thank you, both of you. Oh, the name of the organization is the Sickle Cell Reproductive Health Education Directive, SCRED. And Tiana will put the name of the organization in the chat again for folks. Just do it every 10 minutes, Tiana. And here's a question for our women panelists. How does sickle cell disease impact women and menstruation? So let's start there. It's a two-part question, but let's start with that part.
So growing up, I had a lot of experience with heavy bleeding, and I'm not really sure if that's related to sickle cell directly or not, but I definitely did experience pain. Like the cramping would be so bad that it would kind of send me into a crisis. And even like some of the treatments with the heavy bleeding, like I had to get an IUD placed, and just the placement sent me into a crisis. So I do have experience in that, and that's also something that I see come up quite a bit.
Ms. Snape,
Yes.
want to speak to that a little bit?
Yeah, for me, well, as Phil was talking about, like the late development, I kind of started my menstrual cycle later than basically all of my peers. Um, and at first everything went very well with it, but I would say a few semesters in college, every time I had my cycle, I would have to go to the emergency room, and I was, out of state, away from home, and that was something that was like not traumatic, but it really affected me. And I think just from maybe like the stress from nursing school, being away from home, being in college, trying to take care of your own self, that probably played a part in it. But after those first few months, I kind of, I don't want to say grew out of it, but it stopped, fortunately, and I haven't really had too many issues with it.
And the other part of this question was about whether there's anything that you have specifically done to prepare for your monthly cycle. So do you keep a calendar? Do you anticipate having pain? Is there anything that you do specifically?
I have taken birth control pills for quite a few years, honestly. And so I will know like when my cycle is coming. So mostly when I was doing nursing, also full time, I would try to schedule my shifts around that because I know I would be up on my feet all day, running around the units, and that puts stress on your body. And I wanted that time to kind of sit and relax and nourish myself during that time. So I try to schedule around it and not do too many high impact activities.
Great. One thing, Tiana, that you made me think about that, sorry, we'll ask that question in a minute. One thing that your question about your comment about getting an IUD made me think about, just in terms of thinking about contraception choices and birth control choices, I always worry that my patients have had a lot done to their bodies. You have been hospitalized a lot. You have, even if you are fortunate and have not been hospitalized a lot, you have had a lot of blood draws, and that has happened to you your whole life. And so I always feel sensitive that even though I have opinions about what the best contraceptive choice might be for any individual patient, that recommendation may or may not adequately account for the traumas that you've experienced in your body. And I wondered if you could talk a little bit about how you think about sexual and reproductive health and your body, which has been through so much as an individual with sickle cell disease, and how that shapes things. That's a big question. You can take it in any direction you want.
That is a really interesting question. I don't know that I've ever really sat down and unpacked that. I think that maybe because we have been through so much, that's probably why I haven't really considered it, like whatever complication comes my way, whatever treatment I need to do, it just kind of is what it is. It is what it is. So that's interesting. I'm curious to hear from the other panelists about their perspective.
Brittany, I'll yield to you on this one.
I'm trying to sit and think. So we're saying, how are we, from all the things that we've been through, how does that
let me make it really concrete.
Okay.
Sometimes I think, so for example, I think IUDs get really short shrift in the sickle cell community, by which I mean, I think they're a fantastic reproductive control option. That was a poor choice of words. They're a fantastic contraceptive option, right? They're great at pregnancy prevention, and you take them out and we think you can become pregnant after they're removed, but they're not used very much by individuals with sickle cell disease at a population level from what we can tell. And one of my concerns is always that you've had so much done to your bodies, you've been through so much, that it's like one more thing, if you can just skip having one more experience that might cause pain, that even if you agree that there are potential benefits to the treatment, that maybe just one fewer therapies would be something that is preferable. Does that make more sense as a question?
Yeah, thanks for being so sensitive and mindful to our experience.
Yeah, I think it's definitely something to be mindful about. But since there are so many things, and sometimes it seems like it's kind of never ending. So I mean, what would be the, like, I guess you would just have to weigh your options. Like, well, do I want to take another pill every day on top of the 4 pills I'm taking for this and then vitamins on this? Or do I want to like go through this temporary, insertion? So I just think sometimes, like Tiana said, it's just like, you just do what you have to do to get through, to get to the next step, unfortunately. Like, I mean, you want to be mindful of those things, but you have to do it kind of sometimes.
Yeah. But there are more conversations that need to happen around contraception specifically, because I do think, I mean, I know that this is a community or patient population that is like predisposed to blood clots, and then that comes up with oral contraception and people have a fear about that. So
yeah,
it all needs to be taken into great consideration by like all the stakeholders.
And who do you think that people should have these conversations with? So usually hematologists don't write birth control prescriptions, right? But so what do you think is the ideal way or opportunities here for hematologists in particular? As I don't think we have too many OBs today in the audience. And Dr. Rana wants to make sure we know he does write birth control prescriptions, as do I, Dr. Rana. But in general, not all doctors feel comfortable with that approach. And certainly, unfortunately, I don't have the ability to insert IUDs in my clinic. So anyway, I wondered what you all thought about who provides information about contraceptive counseling, and ideally, where are you getting that information from?
Well, that's an interesting question. Oh, you go first, Brittany.
Awesome. I would just say, in a perfect world, it would be collaboration between the hematologist and the OB. I remember I was prescribed birth control pills that had, I think that it was like iron pills as your, I can't remember exactly what the prescription was, but it had iron in it. When I was like reading it, and I was like, this to me. But, maybe that OB wasn't very aware of why I didn't need to have the excess iron when my iron level was already so high. So in a perfect world, I would think just collaboration between the two specialties. And I know that's easier said than done. And even that brings me to think about, like, when with sickle cell, you already know or already labeled like, oh, you're going to have this high risk pregnancy, but what does that mean? Like, how am I going to manage my pain during pregnancy? Are we going to do transfusions, or, what's going to be our method of action to take this on as a collaborative team? So I think the end answer, or the in summary, is collaboration between the disciplines. So
great. And one thing that we were talking about before this talk began was just about, something that I always talk about with my young adults, which is agenda setting, that whenever you come to a meeting, you have an agenda, and that includes doctor's visits, right? And so would you all talk about your approach these days, now that you're fully adults and in charge of your own healthcare and have been for many years? Would you talk a little bit about how your approach to sort of driving conversations about sexual and reproductive health and how you set agendas when you meet your doctors works for you? And any suggestions you have for other warriors who are here today for how they can do that well as they try to have these conversations?
So I guess I'll jump in, since I didn't have much to contribute regarding the birth control and IUD discussion. But I will say, with regards to agenda setting, I will definitely, I mean, the premise of that prior question, Dr. Pecker, was, given so much of what our bodies deal with as far as treatments, and somewhat ironically, from a family planning perspective, one of the less invasive treatments, which would be hydroxyurea, does have potential family planning repercussions or ramifications. And so as far as agenda setting, I recall personally having a discussion with my hematologist when I was in grad school in Los Angeles, shortly after I had originally been married, and we were, planning our family, and who was recommending for me at that time that I began taking hydroxyurea. And we had a discussion, we had a dialogue back and forth about, for one, what are some of the long-term studies indicating, what are some of the risks, and then also more importantly, what is really the upside or the benefit that I would get from assuming a course of hydroxyurea. And at that time, I wasn't particularly symptomatic. I think it had been 2 years since my past hospitalization. And so ultimately my hematologist and I concluded that there wouldn't necessarily be significant upside for me to begin taking hydroxyurea, given that my wife and I were planning, we were trying to have children. And so that was a discussion that, was conditional, though, of course, that had my severity become more frequent, or had I been elevated to admissions to a hospital as many as 2 times in a year, that we would revisit that discussion. And so that was a suitable compromise for me, but it was very imperative to set that agenda as far as what my goals were with regards to planning my family and balancing that out with the needs of my treatment. So that's one example. I'm sure the ladies probably have themselves some good examples as well.
I have a follow-up question for you. Did you ever have a semen analysis performed as part of this conversation?
No, I didn't. And that might have actually been good to have. I as a collaborator of Tiana and you too, Dr. Pecker, in this reproductive health initiative, I stay tuned. I try to stay pretty dialed into some of the resources you shared. And it was interesting to learn that even not necessarily just within the confines of those of us having sickle cell, but just just kind of the way the motility and things like that around sperm for just men in general over the past 40 years has changed is kind of alarming. And so I do think for those of us with sickle cell, for whom those can our diagnosis can potentially create either comorbidities or some confounding effects, that probably should have been something that would have been worthwhile to have a discussion. But I don't know if that would have been within the purview of my hematologist, or if that should have been under a different specialist. And so had I known better, I probably would have asked for perhaps an appropriate specialist, or for the hematologist to perform that. But I do think that's a good discussion. And fortunately, in my case, there wasn't much of a challenge in terms of actually getting pregnant. It happened certainly much faster than I was ready for, being my first year in grad school, but it worked out. But I think that would probably be advisable for all of us, especially men, to raise with their doctors if you're planning a family.
Great. Do either of you have something specific you want to say? I want to get to a couple questions in the chat box. Otherwise, Ms. Snape, do you have anything you want to add, or you're good?
Just about how I approach healthcare now as an adult is, since I do have a nursing background, I think I'm able to kind of reach from that pocket and try to incorporate that into my doctor's appointments. But also, I am a nurse and I have been specialized, so I don't know everything. So I kind of make sure my doctor knows, okay, hold on, I don't know about everything for genetic counseling. I need you to go over all this with me. And I also I'm very detailed. So I come to every appointment with my notebook. I have all my questions written out, and then I will email my doctor if I have follow-ups. And one person in the chat was asking, do I tell my OB if I have sickle cell or not? And yeah, I mean, when I come to the appointments, I let them know my history, what I'm dealing with, and what my plans are. And while you cannot force people to be collaborative, I do ask, and I do suggest, I say, well, my hematologist is very open. Can you contact them? Or, I ask my hematologist, well, my OB was wondering this. Do you think you can call her? So that's kind of what I do. And people seem to be very open to it.
That's terrific. Thanks. there are a couple other questions here that I want to make sure we get to. So, this is a question in lots of communities. So when is it age appropriate to start talking about things? So, wearing my former pediatrician hat, I want to say we recognize that different stages and ages, people have different developmental needs, and that those developmental stages continue even after you become an adult. There are stages of life that continue to be unfold. And so I wondered if you all had thoughts about how to approach reproductive and sexual health counseling from a developmental standpoint. And maybe you could talk a little bit about what it was like to be maybe 21 or 22, maybe not 12. Or 12, if you remember being 12.
Well, I'll jump in and just reiterate that I think around from that 12 to 16, basically that high school age, where it was very clear that my peers were all growing much faster than I was, that might have been appropriate time to start planting some of the seeds around some of those reproductive health discussions. I would definitely say that from the age of, that probably should be on the agenda of every adult hematologist when they are getting a newly transitioned sickle cell warrior, to begin having that discussion around just general sexual education and what are the potential family planning or reproductive life planning considerations, because there's probably a pretty strong likelihood that there may not have been extensive discussions on a pediatric level. So I think that being said, particularly if you're leaving the home and you're going to college, and you just might do some of the things that happen during those. You might become sexually active. You might have your first girlfriend or whatever, and these will be questions that you'll inevitably have. And so I do think that perhaps especially if we're getting to a place where transition is more of this warm handoff from the pediatric provider to the adult provider, maybe that can be a discussion that is facilitated through that handoff.
And in your families, how did that work with your parents? Like, do you think your parents expected the hematologist to do sex ed and reproductive health education, or do you think that they expected to do that work themselves? And care. It's not just work, it's also care.
Well, speaking only for my family, it didn't happen for my folks, but they're also Nigerian and very traditional. But that being said, my dad is a doctor, my mom was a nurse. So if anybody could have done it in an age appropriate way, it should have been them. But it just, but I did go away for college. I was 2,200 miles away. So I'll give them a pass on that one. But yeah. How about you, ladies?
Well, I agree with you. I think that, when you are in that pediatric world, it's such a merger and partnership between your family and that provider. So maybe if there's some way that they could do it together. I know for me, and I agree with you, Phil, I think that these conversations should start early. Looking back, I did experience delayed puberty, and I don't know if I really understood what that meant exactly. I just know that it was incredibly isolating being in that locker room. So another point that I forgot to make is that when we're having these conversations and trying to figure out who needs to be in the room for these conversations, it would probably help to have like a mental health specialist, because a lot of times we talk about isolation and depression as we age, but we don't really think about that isolation could start as early as like age 10 or before that. So I think that we need to be mindful of that and make sure that the mental health is being taken care of early on.
Oh, you guys are so amazing. So I think we only have a one or two more. Oh, Dr. Rana says it will be so helpful. I was hoping for it would be so helpful. Yes, this is a great end point. It would be so helpful if each panelist would come up with 2 suggestions about sickle cell and sexual health. And we were talking about this before, so I'm going to turn up the heat a little bit. I think I would like you to have 1 recommendation for patients and 1 recommendation for doctors. If possible.
All right, I'm a perpetual color outside of the lines person, so I'm going to give one recommendation for parents, since you didn't say they weren't in your question. And I'm going to reference some of Brittany's comments. I'm sorry, Tiana's comments with regards to kind of how those of us warriors are kind of learning about some of our sexually from each other. In a certain sense, you don't want too much of that to happen for obvious reasons. You want it to be kind of structured and controlled, and the information disseminated responsibly. But I do think, touching on the mental health perspective of what Tiana just mentioned, that isolation and depression can start young. I am a perennial advocate of getting young warriors affiliated with a good camp, the closest CBO to them, even if you have to cross state lines. Help them get a tribe, because sickle cell can be so isolating, so alienating. And sometimes the best cure for that is being having extensive interactions with people who know exactly what you're dealing with. And I think camp can be a great session for that. And that actually might be another context or venue within which you can administer appropriate sexual education. Just a thought. I don't want to give too much new work for the camp counselors, because it is a daunting and busy task watching young warriors. But so that's a thought for them. For the patients, I would say please avail yourself of any opportunities to find a tribe, sign up for camps yourself, bring them to your parents' attention, connect with your local CBO, and make a plan. Make a plan, especially for how you're going to take over control of your care before you turn 18. You want to really hit the ground running and not have to learn a lot of these things just once that switch is flipped and you're now seeing an adult provider. So make a plan both with your parents as well as your pediatric doctor, in terms of what that handoff is going to look like and how you are going to assume greater responsibility for that care. And as pertains to reproductive questions, if you feel bold, break the ice and raise the question on what you should know, what you might want to know sexually with regards to sexual health. I didn't want to take up too much time, so I'll yield to the ladies on their perspective.
That's great. And I want to also sometimes feel, I think we get lost a little bit in what's unique about being an individual with sickle cell disease, and what's very human about being an individual with sickle cell disease. And something you said that made me chortle a little, laugh a little, is that yes, people do learn about sex at summer camp. That's something that makes many parents very nervous. So, you flip that around and you give the counselors some control. That would probably be very reassuring to a number of parents in the audience. Okay, advice from Ms. Snape and Ms. Wolford.
I think my advice for both patients and providers is actually the same. I know that I've already conducted a couple of focus groups related to my organization, and I wanted to focus on warrior education and empowerment. And the concern is they don't feel that their providers are even equipped to have these conversations with them. So I think that for both groups, we need to make sure, Dr. Pecker, this is something that I got from you, we need to make sure that these are not hand on the door conversations and things that are like not being brought up at all, or things that are being brought up at the very end of the appointment. So I think we just need to work together to make sure that reproductive health care is like standard of care.
Great. Pearl from Ms. Snape, please.
I think my advice too would be the same for patients and doctors, and it's to just start the conversations early. For providers, we ask about, are you exercising? Are you eating right? But we could also incorporate those type of reproductive health questions or sexual health questions into that conversation as well. Like, well, are you interested? Well, I don't know. Is that too personal? But you can ask the child, like, how are your relationships with others at school? What is this is how I asked my sister, what is the conversation you guys are having? So just getting in there. And then for patients, it's harder to think about, I guess, as you're younger, what you want to do in the future as far as family planning. But if you can even just think about like, well, maybe that sounds like an idea. Maybe I would want to have a child in the future. Just start that conversation early with someone you can trust. There are no dumb questions, no stupid questions, and do your research, because you are your best advocate. So that's how you have to show up.
Great. What a tremendous way to end this session. Thank you both, and thank you to our wonderful questions from the audience. Thank you, all three of you. And you know, I hope we'll get a chance to do this again. And
Thank you, everybody.
and thank you most of all to the team at Howard for this wonderful opportunity and for this great day. We're
Yeah,
glad.
everyone, if you can, come join the closing session. We're going to have a brief memorial and then a few more awards.
Okay, sounds
Bye-bye.
good. Thank you.